Thank you so much. So in this session, we'll be having this wonderful presentation from Heather and Amy. And the presentation is titled The Power of Language in Sexual and Reproductive Healthcare, Harms and Opportunities. I would like you to meet Heather and Amy, and I will share a brief biodata of the two presenters. Heather Bradford is a midwife educator, perinatal health services researcher with a passion for midwifery and women's health. She strives to grow and diversify the midwifery and women's health nurse practitioner workforce to address inequities within perinatal care, specifically related to weight bias and improve perinatal outcomes. Heather serves as the Assistant Program Director for the Nurse Midwifery and Women's Health Nurse Practitioners Programs. And she was selected in 2024 as the Mary L. and Raymond T. Olding Endowed Professor for Maternal and Infant Health with the Georgetown University School of Nursing. She was a 2019-2021 Georgetown University Medical Center Bias Reduction Improvement Coaching Program trainer, and in 2024 was an inaugural member of the Health Equity Influencers Program, HEIP, for nurse educators. Heather joined the Georgetown University Teaching Academy for the Health Sciences as a principal member in 2024. Clinically, she serves as a full-scope midwife from 2002 to 2024, attending almost 800 births. She became a fellow of the American College of Nurses Midwives in 2011, and she has published many articles in peer-reviewed journals and chapters in leading midwifery and women's health textbooks on advancing health equity in nursing education, midwifery workforce development, and weight bias. Heather is an associate editor of the Clinical Practice Guidelines for Midwifery and Women's Health. She recently completed a PhD in nursing science from Vanderbilt University School of Nursing, studying weight bias among midwives. Thank you, Heather. Amy Gore. Amy is a midwife at Cambridge Health Alliance, and she's on the faculty at Thomas Jefferson University's midwifery program in the US. She completed her PhD last year at Boston College, where her research examined digital health equity in pregnancy. She has been a midwife for over a decade, working in diverse settings from birth centers to large academic teaching hospitals. She's on the American Association of Birth Centers Board of Directors and is currently a commissioner on the Commonwealth of Massachusetts Asian American and Pacific Islander Commission. Prior to Amy's midwifery career, she worked to improve and better understand the complexities of health and rights in global communities. After a stint as a Peace Corps volunteer in Cape Verde, she completed her MPhil thesis in international development, investigating the socio-political aspects of maternal mortality in Brazil. Amy's research interests include midwifery and birth center utilization amongst Asian Americans, data disaggregation, midwifery workforce, respectful maternity care, and digital health. Please join me to welcome Heather and Amy. Over to you.
Thank you so much, Adetoro. It is just a joy to be with everyone this morning. I see familiar names, students and colleagues and midwives from all over the world. So thank you so much for being with us. The sun is just rising here in Seattle, as you can see in my camera. So it's really wild to think about us in all parts of the world coming together this morning. So thank you so much for being here. We can go to the next slide.
Yeah, I've given you control, Amy and Heather. If you want me to as well, I don't mind.
Oh, actually, yeah, if you could, that would be great,
Yes,
Adetoro.
I have. Yeah.
Excellent. So, Amy and I are excited about this presentation. This is really, I would say, a work in progress. Language is constantly changing and developing, and I really see myself very much as a learner in this work. But I think it's really important to have this conversation and talk about this topic because it really feels like a very important part of advancing health equity and really thinking about respecting our patients and really promoting optimal quality care. Let's go to the first slide on our objectives. Can you scroll down, Adetoro?
Okay.
Excellent. So these are our three objectives. We plan to talk about the harms in both written and spoken language, specifically in the electronic health record and our peer-to-peer communication when we're talking with each other or with students, and then, of course, in interacting with our patients. We want to also highlight the specific communities and individuals that are most affected by harmful words, so we can be especially careful in our language there. And then we're going to really focus on current recommendations for patient-centered and inclusive language. We have two specific case vignettes that we're excited to work through with you. And then at the end, we're going to share a QR code, which has a resource guide that Amy and I are developing. It's really a work in progress, and our reference list. So if you could put in the chat, we have a question that we think would be really helpful for us to think about together, is if you have received any teaching on this topic of the use of either social identities or stigmatizing language in your communication with others or patients and documentation. So let's just take a minute and just share, if you could, if you've received any teaching on this topic, just so we have a sense. Great. Well, that's really helpful. Gives us a good sense. I know one of my peers, Cindy Farley, is here, who's published on this topic. So wonderful to have you here, Dr. Farley. Let's go on to our next slide. So we want to ground ourselves in our framework. I mentioned that this work is really focused on promoting health equity, and it's really using a trauma-informed lens. But our framework is really based on the reproductive justice framework, which is listed here. Access to safe and respectful sexual and reproductive health care is a basic human right. And we really want to just, I think, step back a little bit and think about this is really, as I think about when I first became a nurse and as a midwife, thinking about our ethics and our lens of beneficence and doing no harm. And really, that's where reproductive justice is framed in that, in centering the patient and their bodily autonomy. I want to credit Sister Song, which was really developed in the 1997 by 16 organizations of women of color from 4 different communities, both Native American, African American, Latina, and Asian American, who recognize the rights and responsibilities to represent themselves and their communities. And so I really want to just recognize their work. Let's go on to the next slide. So there's been a lot more recent literature on respectful care and in sexual and reproductive health care. And what does that mean? And there's been some studies that have specifically looked at reports from patients that we're caring for that they are receiving mistreatment, disrespectful care. There, one particular study I'd like to highlight by Vidam in 2019, which is on our reference list, which basically found that 1 in 6 women report experiencing mistreatment either loss of autonomy, being shouted at, scolded, being ignored, refused, or receiving no response in their request for help. So women basically in this study, the rates of mistreatment were higher among patients of color, and it was not related to socioeconomic status. So racism that's occurring, but specifically 1 in 6, I think, is just for me really hard number to hear. So I think we have a lot of work to do. Just mentioning other reproductive injustices, not obtaining consent when this has been going on for centuries, really decades, more recently being published. And then, of course, pain management, not providing adequate pain management for patients based on their skin color. And then, of course, violations of privacy. But Amy and I conducted a lit review and really started gathering data around language. There's a lot more that's been published around language, specifically within the electronic health record, maybe through use of natural language processing and AI, but really looking at oppressive language in our written and spoken words, really based on discrimination and bias. So let's dive deeper into this. We created a table. On the left is where we've really been, that we've made treatment decisions and sort of not included patients in our decision making. It's really been focused on risk and laden with blame. And we're challenging us all to move to the right side, which, as you know, as midwives, we know is really in our ethos. But I think oftentimes we're sort of used to practicing a certain way and maybe not thinking about the clinical jargon that we might be using. We're not including perhaps patients in our decision making, and we're also not referring to that in our written and spoken language with our peers, with our students, and with our and in our written electronic health records. So really getting into it, Amy and I came up with 6 different categories. Let's go to the next slide, of different ways that language can be harmful in sexual and reproductive health care. And so we're going to break these down one by one. This is, could you go down just a slightly bit more, Adetoro, on that lower right? There's a lot of resource guides that have been published on this topic. So we've tried to capture all of those. And there's been a lot of language written that is really it infers a power dynamic or has maybe a violent or derogatory tone. So I think this is especially important because now patients are reading their electronic health record. In a decade ago, when we were still in paper charts, patients were not reading what we wrote. But it's not uncommon for a patient to read the record and feel very dehumanized and what they're reading about their note that was written today. So this feels especially important that we really make a change in our language. So I'm going to talk about the first few here. Let's go to the, actually, no, let's go to the next slide, Adetoro. I want to, as I mentioned, this can be based on implicit bias. And for definitions, I wanted to take a moment and help us all understand what implicit bias is, the automatic unconscious activation of stereotypes. And, these are not something that we can get rid of. It's really about mitigating our bias. We all have implicit bias, but it's really about mitigating that and being intentional in our words that we use and in our clinical decision making. And if you aren't familiar with it, I encourage you to go to the Harvard Project's Implicit Association Test, or the IAT. It's a free test that you can take. You just type in Project Harvard IAT Implicit Association Test. It takes about 9 minutes, and you can pick any particular bias that you're interested in exploring about yourself. I'm, of course, as Adetoro shared, one of my areas of expertise is weight bias. And so you can take a implicit association test related to weight, but also all sorts of other choices for that. So I just want to mention that resource as perhaps a step towards self-reflection. Let's go to the next slide. it's really important that we think about the community that is most harmed in the language that we use. And you'll see in our examples later, this is going to come up again. Thanks, Amy, for putting that in the chat. But these are the communities that are most harmed in our language. People from historically oppressed groups, people who use substances, those with chronic conditions or disabilities, immigrant communities, LGBTQIA communities, those with low health literacy, and then individuals in larger bodies. So I think it's just really important to think about these are the patients that we especially need to be really be very mindful in our communication. What are the side effects of the harm of our language? There's been some literature that has looked at treatment decisions that specifically around racism and based on a patient's skin color, that evidence-based guidelines are not being followed. I would say that's probably the most emerging area of research, but not a lot in sexual and reproductive health care. So thinking about racism and clinical decision making and following evidence-based guidelines, there's not a lot of evidence. I would say that that's something we'll be seeing more of in the next bit of time. I can speak to weight bias in my area of expertise and say that we are causing a lot of harm because of weight bias in the clinical setting. Patients who are not wanting to return for care for contraception and having a pregnancy that was not planned because they're not on contraception, because of harm that they've experienced related to shameful language in the healthcare setting, or being, they're coming in for contraception and being told when they leave the office that they need to lose weight. That's not the reason that they came in for the visit. So a lot related to in the weight bias field. But I think also delays in treatment is also really important to think about. If someone is reading stigmatizing language in their electronic health record, they might not want to come back for care. And so I think it's really important to be thinking about that. So now we're going to dive into these 6 different types of language harms that we came up with. And again, as I say, this is a work in progress, and we really value your feedback today as we're thinking about this. I want to credit one of my Georgetown colleagues, Dr. Corey Williams, who has published in the New England Journal of Medicine about discriminatory language in the electronic health record. And that reference is on our reference list. Basically, Dr. Williams looked at how many times providers are putting the patient's race in the clinical note when it really has no relevance whatsoever. And so I would ask you to perhaps just remove it. There's really many times no reason to include it. Race, ethnicity, culture, religion. There might be times related to a patient's food preference or maybe religious beliefs that does impact care, or that might also impact health-related beliefs or behaviors. And then it might be valuable to include, but essentially it does not need to be included at all. Oftentimes, clinicians are assigning a race based on appearance and many times assigning race incorrectly. So I think it's important to really think about how race is included. One of the things that Dr. Williams talked about in this paper was that racial identity is more often included with negative descriptors of patients. So the race is left out if there's no negative descriptors, but if race is included, Dr. Williams found that many times these words that I've listed here, aggressive, angry, non-compliant, were included with oftentimes the Black race. So a lot of discriminatory language that they found in their study. Let's move on to the next one. This list, I would say, is probably the biggest list of where perhaps I would say I am needing to really think about my language, is stigmatizing, dehumanizing, or judgmental language. You might see words such as they were late to prenatal care or received inadequate prenatal care. Really, that's really not our place to be putting that in the chart note. You could just put in there when they started prenatal care, for example. we've been seeing the abbreviation CC, or chief complaint, for many, many years. We would say chief CC is still fine, but change to chief concern in your language, because complaint has a very derogatory tone to it. We're going to talk in our vignettes about using person-centered language, but really thinking about moving the word that describes the condition to the patient with a substance use condition instead of the substance abuser patient. So really separating the diagnosis from the descriptor of the patient. Elderly, illegal, these are also very derogatory terms. We could just say this patient's age. The patient is 65 years old. Giving up for adoption also has a lot of negative connotations with it. So we suggest placing the baby for adoption. And we're going to be providing a reference list, as I said at the end, that has many of these examples. I also want to call your attention to the use of mistrust. It really refers to the patient's lack of trust in the clinician or in the healthcare system, but mistrust really implies that the patient is wrong about it. And so we instead recommend the word distrust. So really thinking about how our words can express doubt and really questioning the patient's what they're saying. And we obviously want to always, the patient is, their feelings are most important to be validated. Let's move on to the next one. Dr. Williams also talked in their study about the use of quotes, and this was a real learning opportunity for me. Oftentimes I've found, well, if I just use the patient's exact quoted words, then there's no a possibility for me to be putting any of my potential perception around that or feeling. But I would just encourage you to use judgment when you're using quotes, because the context really does matter. We might use quotes such as, the patient is adamant that she has a headache, or the patient apparently has a headache, and put that in quotes. And I think that it's really, you can see that there's some judgment here in this. The patient claims, again, we're inferring that the patient is not, that's what they're saying is not true. So using direct quotations maybe might seem to elevate their voice, but it really can covertly communicate stigma. And so I think it's really important to think about this. It might be appropriate in some comments or in some chart notes, but oftentimes it can be filled with stigma. Let's go to the next one.
Thanks so much, Heather. So research has really demonstrating that appointments with midwives and other clinicians, they may be conducted in heteronormative language. So research has demonstrated that 1 in 3 clients seeking contraception care in the United States actually identify as part of the LGBTQI+ community. One study in the United States done in 2023 surveyed around 1,400 reproductive age people assigned female to birth. And actually participants in the LGBTQI+ community were more likely to experience pressure to use contraception compared to their heterosexual counterparts. Additionally, LGBTQIA+ participants reported frequent heteronormative assumptions during contraceptive care. Therefore, it really is essential to avoid language that makes assumptions about people's sexual identity and using heteronormative languages. You can see here, these are some phrases that actually utilize exclusionary language, such as saying, how many men have you slept with? Are you monogamous? What type of birth control are you using? Does he use condoms again? Just as I mentioned in that study, these assumptions about people's sexual identity and sort of the pressure to use contraception. This comes up often. Additionally, using terms such as natural birth really indicates that there are types of birth that are unnatural. This language places value on certain types of birth, which could cause shame and inadequacy in birthing people. So terms such as using vaginal or surgical birth may be preferred. Next slide, please. So there are some words and phrases in reproductive and perinatal care that are violent, derogatory, or shaming. Some of these examples are here, such as stripping the membranes, breaking the bag, or performing an emergency cesarean section. While a cesarean or surgical birth may be urgent, the word emergency can be really alarming, particularly when describing a birth. Patients are sometimes labeled or described as having failed the 1-hour test, failed an induction, or having an incompetent cervix, or a cervix that's insufficient. The language of failure, incompetence, and insufficiency imposes judgment on the client and their bodies, which really fosters feelings of shame and self-doubt. In the public discussions as well, there on certain conditions may be phrased in violent ways, such as if you use combating diabetes or eliminate or for example, using the phrases the target population. Other phrases that might be better to use are the intended audience or the population of focus or eliminating diabetes. Next slide. There are phrases in midwifery that may indicate that the client or birthing person is a passive participant in their care by the language that midwives and other clinicians use. This language may reinforce the hierarchical power pyrodynamic that undermines the shared decision-making and overlooks that social and structural determinants of the client's health. Referring to the birth as a delivery, rather than recognizing it as a profound psychophysiological experience and a transformative passage into parenthood, really diminishes its significance. As midwives, we often use the term catching the baby instead of delivering to emphasize that it's the birthing person, not the provider, who actually deserves the credit. These are some other examples that you can see that really highlight that power dynamic and sort of documentation that might come in the medical record. Or even conversations that you might have with other clinicians, such as, oh, let's give her the depot at discharge. Or you've had, talking to the client, you've had 4 babies already, you need to get the tubes tied. So again, there's none of that patient-centered care, no shared decision-making. Next slide, please. So unfortunately, advances in reproductive and perinatal health have mostly been have been credited to white cisgender men. So you can see these are just a few of the terms. We include a more expansive list in our resource sheet, which we'll be sharing with you. Textbooks written for health professionals, perhaps the ones we've seen also in our midwifery education, continue to name the procedures and the anatomical structures after men who first wrote about them. I think one of the most commonly cited ones is cesarean section. This is credited to Julius Caesar's mother, Aurelia, who birthed Caesar, but it's speculated that the origins of the name is actually derived from the surgical births that occurred during Julius Caesar's reign. Additionally, female anatomy has strong historical gendered nomenclature. For example, the Italian anatomist Gabriele Filippio in the 1500s first described the tubes that connected the ovaries to the uterus as fallopian tubes, and now they're called as such. Many of the procedures in anatomy are named after men, but also there are some that are actually indicated as being possessed by men who first described these structures. For example, the greater vestibular glands located on the vestibule of the vulva are often called the Bartholin's glands, named after Caspar Bartholin Secundus, who noted them in his work as an anatomist. So again, these are a few of the other examples that you can see. So we have a little bit more work to both change the language in our own sort of documentation, but also in our textbooks that we're using for education purposes. So here, we really hope that you've been able to sort of absorb some of these guiding principles. The first one being, really utilizing a non-discriminatory, patient-centered, strength-based language. Again, using that person-first language. Being able to promote patient autonomy and shared decision-making. and also reference to procedures and body parts as they are, and not after a cis white male who had first noted them. So we have 2 vignettes and exercises. So this is meant to be a little bit more interactive, and we're really hoping that you can participate. So we'll be reading documentation that you might find in the health record in a client's chart. I'm going to read it out loud, but also please feel free to read it yourselves. And I'd like to actually, for you all to write in the chat any words or phrases that you might modify due to it being discriminatory, violent, or exclusionary. So in this first vignette, Essay is a Black elderly alcoholic obese woman with a chief complaint of alleged vaginal bleeding for 3 months straight and a back breast lump. She also has uncontrolled diabetes. She said she hasn't seen a provider for years due to mistrust in the healthcare system. She denies ever having a mammogram. She is accompanied by her disruptive grandchildren. So if you could just write in the chat, you don't have to tell us like how you would change it, but just some words that you feel like would be problematic based on your own learning that you've had, perhaps from our talk today. And you can just drop those in the chat. Great. Thank you so much, Claire. Great. Yep. So seeing Black, elderly, obese, complaint, alleged, elderly, disruptive. Yep. Yep. These quotes. Great. Thank you so much for your participation. Yep. Perfect. Adetoro. Yep. So we've highlighted here in red some of the problematic language that was being used, and I think you all had actually covered all of it. So Black, elderly, alcoholic, obese, woman, complaint, alleged, uncontrolled, diabetes, mistrust, denies, disruptive. Yep, all those things. I think you all have already. So now we've cleaned up sort of the documentation. Next slide, Adetoro. Thank you. As you can see, the first paragraph was the previous documentation. And so we've modified it to essay is a 56-year-old cisgender woman with 2 primary concerns, vaginal bleeding for 3 months and a breast lump. She has diabetes and alcohol use disorder. Her last hemoglobin A1C was 7.9. She has not previously had a mammogram. Her last visit was in 2002, and she does not have a regular clinician. She reports experiences of racism in previous healthcare encounters and distrust in the healthcare system. Okay, this is the next vignette. So again, please, I'll read it. Just please drop in the chat any problematic language you'd like to modify. PG is a teen mom, 17 years old, gravid 3 para 1 011 at 39 weeks and 3 days. Here because she complains that her water broke. She arrived by ambulance without any contractions and her clothing is completely dry. She was late to prenatal care and desires a natural delivery. Okay, so teen, broke, complains, late. Yep. Great, thank you. All right, we'll move on to the, yep, late, natural, completely dry. Yep, I think that you all addressed most of them. So teen mom, complains, arrived by ambulance, clothing completely dry, late to prenatal care, natural delivery. These are some terms that perhaps either we should exclude or modify in some way. And again, the second paragraph is the modification. So I'll just go ahead and read it. So PG is a 17-year-old gravid 3 para 1 01 at 39 weeks and 3 days. Patient noticed rupture of membranes at 1600 for clear fluid and states there was only scant fluid since then. Patient states she's a primary caregiver of a toddler and mom who was hospitalized recently. Patient desires unmedicated vaginal birth. Okay, so hopefully those exercises are a little bit useful. And really the take-home lessons are really understanding that, do you mind scrolling a little bit further down, Adetoro? Yeah, perfect, thank you. Humility is really an underrated superpower. So really evaluating yourself and your own biases that you may have in providing care and even in your documentation. As Loretta Ross, the Venerable Loretta Ross says, calling others in and yourself is a great first step. Use person-centered, non-stigmatized language. That is key. Again, both in your interactions with patients and in your documentation, it really is a quality and safety issue as well. Really changing this language and disrupting that language really is promoting health equity. We know that this work is all work towards anti-racist midwifery care, and really that great documentation and good and quality patient-provider interactions really can help to dismantle racism and biases in healthcare. And it's a constant learning journey. It's always changing. It is a lifelong assignment. So continuing to reevaluate, looking at the different trends in language and what we're doing is essential. So if you have time, we'd love for you to just pop in the chat. What is one area of patient-clinician communication and documentation that you will change to mitigate bias or stigma and improve the quality of midwifery care? Just based on what you've learned today, if you have time, if you'd like to share, you can drop that. And then if you scan this QR code, you have our reference list, our resources, and again, that table of terms that might be problematic and what are the preferred terms. And we ask for your opinions and, welcome your, just as we stated, that it's always a journey, and we welcome any sort of feedback that you have for us. Thank you very much.
Thank you so much, Heather and Hebe, for this very important, highly insightful presentation. And thank you for the take-home lessons, reminding us or calling us, charging us to be very, very mindful of our language and how we think as well, in terms of being thoughtful, and also in terms of how we document in the healthcare system. I don't know if there are questions from the audience. I know there have been a lot of inputs in the chat box talking about the importance, of our language and the need for us to be very mindful. And there are lots of comments about how great your presentation has been and how very insightful. I know there were some earlier comments in terms of the importance of evidence-based medicine and the fact that EBM is about science and the science made by privileged and white, and you talked about that, as part of your presentation. There was a call for more training and retraining, and that is very, very essential towards curbing foul language from us healthcare providers and the need for us to imbibe culturally competent care. I can't really see any questions, but I'll just ask one as we quickly round up the session. And that is, if I want to start, being conscious and ensuring inclusive language in my organization, where do I start? Eva and Amy, where do I start?
Yeah, and I see Melicia's question in the chat. Well, I think it starts with self-reflection. I mentioned the IAT. I think oftentimes we're not really aware of particular bias that we might have. And I think also I find it's really interesting to just listen to what we're saying. If you're hearing a peer, like a colleague, give report to another colleague, and if you were a patient standing there and heard that conversation, I mean, there's just our language is, just so many words that are just, there's so many problems. So I think it's really important to just listen. I would say is step number 2. Amy, anything you'd want to add?
Yeah, no, absolutely. I think that's definitely the first step. I think that if your institution, your hospital or academic institution has either DEI departments or committees like anti-racism committees that you are a part of, or I think that's the first great step to join those committees to be able to promote inclusive language. And any statements that do come out based on those committees, I think being able to incorporate that language is key. I know that for me personally, we've done that in several organizations I've been a part of, and I think it's really been useful to provide those resources to not just internally within the department, but also externally to the community.
Thank you. Thank you so much. There is a question from Jane in the chat asking about how do you educate medical staff. I know you started talking about it, Amy. I don't know if there's anything you want to expand a bit more on that.
Yeah, this is really an ongoing process. We can't just change our language overnight. So I think really thinking about it, practicing it, I think it needs to start in our textbooks, and it needs to start in the articles that we're writing and publishing, because if we're reading the language, then that's going to help, that sort of ripple effect. I think it's just really there, as I said, as Amy said earlier, this is a lifelong process. So ever changing. And I put in my email in the chat. If folks have other suggestions, the resource guide that Amy and I put together is really a work in progress. So very open. There's a lot of great resources that we're pulling these from. We've got a long resource list there. So if you have other resources you'd like to add as well. I know we're at time, so we should end there.
Okay. There are other questions in the chat. One asking about some of the terms that you mentioned that should be avoided. I want to say, Gail, Melissa, Heather's and Amy's email addresses are on the screen. Please feel free to reach out to them. And if you don't mind also, Heather, responding to some of those questions later. So I want to, with that, say thank you so much for your active participation. And thank you, Heather and Amy, for this very, very highly engaging and interactive presentation.